thromboembolism. So I'll narrow down to venous thromboembolism in cancer patients. So as we know that in critically ill patient itself, thrombosis manifestation in the major veins and the dead end complication of venous thromboembolism, that is pulmonary embolism, causes bad outcome in terms of both mortality and morbidity. So when patient with a oncology background, if they had this pulmonary thromboembolism secondary to venous thrombosis, so then the outcome further is going to be compromised. So to make the session interesting, I'll go through one of the real case scenario. So she was a 55-year-old lady, came to emergency department with pain and swelling in the right calf region, which was warm and red. So she was on chemotherapy for multiple myeloma. She was receiving thalidomide and dexamethasone with doxorubicin as a part of chemotherapy. On examination, she was having pitting edema, erythema, so increased temperature in the right calf region. So there was increase in the diameter of the right calf by about 3.5 centimeter as compared to left calf region. Tenderness was there in the popliteal vein palpation. So our platelet counts were 40,000. Coagulation profile was normal with the dilemma of drop in platelet trend and with this swelling. So she was considered for limb elevation with magnesium sulfate dressing for about 5 to 6 days with off dosage of some sort of fractionated heparin. She was started on 5,000 units Q8 hourly. Then she was shifted to ward in the due course. Within 24 hours of shifting to ward, she had a sudden breathlessness. She was hypoxic, had severe hypotension and cardiac arrest. So while giving the CPR, immediately she shifted back to ICU. The ICU done the echocardiography, which shows severe dilatation of right atrium and right ventricle. The diagnosis was very clear. She had acute pulmonary embolism with a severe unstable hemodynamics and cardiac arrest. So continued on the cardiopulmonary resuscitation. She could not be revived and declared dead. So here one dilemma to start on full-fledged therapeutic anticoagulation was she was having some sort of thrombocytopenia. So started on some anticoagulation in a midway dosage that was not adequate. So why I make a point here is, so patient who had thrombocytopenia doesn't mean that they will not develop any thrombotic complication, because thrombocytopenia also can manifest with thrombotic manifestation, because both are different pathway in terms of hemostasis. So thrombosis is a general term for formation or presence of thrombus, so which means a clot of coagulated blood in blood vessel. Thrombus can develop in vein, artery or heart, particularly left atrium, to have a left atrial thrombus, particularly in atrial fibrillation patient. And they can have microcirculation problem, microthrombi, particularly in thrombotic microangiopathy, or it may be DIC or in septic patient. So thrombosis in cancer patient is more common in venous circulation. So basically in the body we have a hemostatic balance. So it is a balance between procoagulant factors and the anticoagulant factors. So naturally in the body we have protein C, protein S, antithrombin 3, heparin. Main important thing which helps in preventing the thrombus formation is so easy flow of the blood and the intact endothelium. So intact endothelium is the best anticoagulation which is naturally available in the body. So when there is a imbalance between the procoagulants and the anticoagulants, patient can have a manifestation either bleeding or thrombotic manifestation. So just for completion's sake, we know that when there is a breach in endothelium, which may be secondary to sepsis, trauma, surgery, or some inflammation, so which will activate one hand, we call it as primary hemostasis, that is the platelet involvement, and other hand, that is the secondary hemostasis, where there will be activation of coagulation factors. So when there is an activation of the platelet pathway, that is primary hemostasis, so which leads to release of the platelet components which have some sort of acidic phospholipids, so ADP, thromboxane A2 platelet activating factor, so which helps in further aggregation of the platelets, so which form a platelet plug. So each step of primary hemostasis will have a positive feedback mechanism on the secondary hemostasis. In the secondary hemostasis, when there is breach in endothelium, there will be exposure of subendothelial collagen tissue. So this leads to activation of both extrinsic pathway and intrinsic pathway. Particularly in extrinsic pathway, factor 7 is involved. In the intrinsic pathway, which we also call it as contact activation pathway, so factor 12 and factor 11 are going to be involved. So when we give warfarin, which acts on extrinsic pathway, there is a vitamin K antagonist, so we measure PT, prothrombin time, or the INR. When we give heparin, which preferably act on intrinsic pathway, so we measure APTT. But when you give high dosage of either heparin or warfarin, so they can affect both the pathways. Both can affect the common pathway also, that is 2, 5 and 10 involvement. So finally, there will be activation of factor 10 to factor 10A, prothrombin to thrombin, fibrinogen to fibrin. So this thrombin and fibrinogen will have a positive impact on the platelet aggregation. Finally, with the fibrin and the platelet aggregation, we have a full formed thrombus. Now to remember, so fibrin formation still can happen without involvement of the platelets also. That's why patient who are thrombocytopenic still have some risk factor to get activated the like secondary hemostasis with the formation of fibrin deposits. So when it comes to oncology patient, there are some facts we have to understand. When it comes to venous thromboembolism, about 18% of the patient with the malignancy had venous thromboembolism. Again, about 10 to 17% who had diagnosis of the new malignancy were having some sort of venous thromboembolism, and they had diagnosis in the next 2 years with some sort of malignancy. So again, 15% of the patients with a malignancy have venous thromboembolism manifestation. So as many as near to 30 to 50% of the patient had venous thromboembolism when they undergone autopsy. When it comes to recurrence of the venous thromboembolism, patients with malignancy had 7 times increased risk of recurrence as compared to the patients without malignancy. Again, when it comes to some facts related to type of malignancy, so venous thromboembolism incidence is more common in high-grade glioma, multiple myeloma with the chemotherapy like thalidomide and steroids, renal cell carcinoma, solid tumors on anti-vascular endothelial growth factor and some other chemotherapy. So these are the type of cancer they have highest incidence of venous thromboembolism. Again, so can this venous thromboembolism is just a manifestation of hidden malignancy? So there was a study called SOMIT study, screening for occult malignancy in patients with symptomatic idiopathic venous thromboembolism trial. So which conclude most cancers are diagnosed within 4 to 6 months of diagnosis of DVT, and 40% will have like metastasis at the time of detection. So maybe DVT is the initial manifestation of some hidden cancer itself. So greatest risk of DVT is within few months of diagnosis of the cancer. But again, the question is, any patient who had some sort of DVT, is it worth to screen them for some hidden malignancy? Answer is no. It may not be cost effective, because it doesn't mean like you screen all the patients who present with DVT to with some PET scan or some cancer markers to identify the hidden cancer. Even National Comprehensive Cancer Network doesn't recommend screening all the patients with venous thromboembolism for hidden malignancy, which is not cost effective, just a time consuming. So basically, we know that pathophysiology of thrombosis revolves around Virchow's triad, which is a basic pathophysiology. There will be stasis, vessel injury, and hypercoagulable state. So just the modified Virchow's triad is going to happen in malignancy. When it comes to stasis, there will be prolonged bedridden in some advanced malignancies, maybe hematopoietic stem cell disease, means hematopoietic malignancies, or maybe solid organ malignancies. There might be extensive compression of blood vessels secondary to tumor, or there may be vessel injury, which may be because of the direct invasion by the tumor or tumor released cytokines. Prolonged use of central venous catheter for the purpose of chemotherapy can cause irritability in the vessel and can cause vessel injury. So endothelial damage can also happen because of the chemotherapy agents. Hypercoagulability, so it is because of the release of tissue factor, tumor necrosis factor from the active malignant cells. There will be impaired endothelial cell defense mechanism, particularly the naturally available anticoagulants in the body like antithrombin 3, protein C, and protein S deficiency will be there. So there will be enhanced selectin integrin mediated adhesive interaction between tumor cells, vascular endothelial cells, platelets, and host macrophages, which finally trigger primary and secondary hemostasis, which leads to the formation of thrombosis. So basically, it is just a in and around some modification of this Virchow's triad, which still apply to the formation of thrombus in cancer patients. So, nutshell, there will be chemotherapy agent which cause release of pro-inflammatory cytokines like interleukin 1, 6, and 10 alpha through the activated neutrophils, which cause endothelial disruption. Again, the malignant cell interact with monocyte macrophage, which act some procoagulant activity. So that leads to activation of factor 8 to factor 12 to factor 12A. So then factor 10 to factor 10A. So finally prothrombin to thrombin, fibrillation of fibrinogen to fibrin clot. So both tumor cells and the chemotherapeutic agent have an impact on the pathophysiology. So overall, the risk factor, there are some non-modifiable risk factors which are related to patient, like his age, sex, ethnicity. The patient is having already some comorbid condition, like patient is a smoker, so diabetic, hypertensive, some prothrombotic mutation. So or the risk factor may be tumor related factors like type of the tumor, the site of the situation of the tumor, which stage, duration of malignancy. All these have an impact on the risk factors for the development of venous thromboembolism. Treatment related, chemotherapeutic agent itself, hormonal agents, anti-angiogenic agents, erythropoiesis stimulating agent, mechanical therapy like what we use central venous catheter for administering chemotherapy, type of the surgery. If the surgery is prolonged more than 1.5 hours, it is an independent risk factor for developing venous thromboembolism in cancer patient. Again, can we predict based on some predictive model for chemotherapy associated venous thromboembolism? So there is some proposed model. So the parameters they included, The patient had CA stomach and CA pancreas. The risk score is going to be 2. And CA lung, lymphoma, gynecological malignancy, bladder cancer, testicular cancer, they have a score of 1. So if the patient had thrombocytosis more than 3.5 lakh, drop in hemoglobin pre-chemotherapy less than 10 gram, or use of erythropoiesis stimulating factor, or they have leukocyte count more than 11,000, body mass index more than 35. Together, if the score is 0, so then they are low risk category. If the score is in between 1 to 2, they comes in intermediate risk category. And if the score is more than or equal to 3, so then they are high risk category. Next question is, can we use most commonly used risk stratification score for DVT like in other patient group? Because this well score include active cancer as one of the risk stratifying score, along with other stratification scoring like parameters, bedridden, cough swelling, so collateral superficial veins, entire leg swollen. So together, if the criteria points are between 3 to 8, they are high probability of the DVT. 1 to 2, moderate probability. So if it comes -2 to 0, low probability. But you have to remember, this well score is meant to be used in outpatient and emergency department. So like that, we have one more score for prediction of venous thromboembolism, that is PADAO score in hospitalized patient. It also includes the active cancer as one of the criteria. If the score is less than 4, low risk for venous thromboembolism. If it is more than or equal to 4, high risk for venous thromboembolism. But you have to remember, any of these prediction scores had lack of validation, sensitivity, and specificity is varied in different group of patients. So it is our clinical judgment, patient clinical manifestation in terms of symptoms and signs, and the therapy they received, so their hemodynamics, their body weight, their immobility status, all these things helps in predicting the risk for venous thromboembolism than sticking on to any particular prediction score. So when it comes to prevention aspect of venous thromboembolism in cancer patient, we can classify to 3 different scenarios. Patients who need primary prevention for venous thromboembolism, like the patients who came for daycare chemotherapy, they are ambulated, or the patients who need medical inpatient admissions who are on chemotherapy, or the malignancy patient with surgery. When it comes to ambulatory patient with chemotherapy, so we need to have some risk setting, risk stratification. Patient receiving highly thrombotic anti-angiogenic therapy like thalidomide, lenalidomide in combination with high dose steroid like dexamethasone, they are high risk to develop the venous thromboembolism. Multiple myeloma patients with 2 or more individual or myeloma risk factors. So in them again, even though they are ambulated, so we need to consider them for primary prophylaxis. Can consider either low dose warfarin for about 6 weeks to keep the INR somewhere between 1.3 to 1.9. Low molecular weight, particularly enoxaparin, we can consider 1 milligram per kg once a daily for 6 weeks. Or like we can consider factor 10A inhibitor, that is apixaban 2.5 milligram twice a daily. So as a part and parcel of prophylaxis. When it comes to inpatient with a chemotherapy, we can consider enoxaparin, tinzaparin, deltaparin, or maybe fondaparinux 2.5 milligrams subcutaneous daily as a prophylactic dose. Unfractionated heparin 5000 units we can consider 2 times daily. Again, so since these patients are little bit more risk to have the venous thromboembolism, we have to maintain INR in between 2 to 3 when we use warfarin. When it comes to surgical patient, so immediately post-operative patient have some relative or absolute contraindication for anticoagulation. So We can consider mechanical prophylaxis like electrical cuff stimulation, intermittent pneumatic compression devices, graduated compression stocking. There is no evidence standalone using the stocking for VTE prophylaxis. Can use venous foot pump devices also. But we have to remember, as early as possible, we have to convert them to pharmacological therapy, which is same as that of the medical inpatient with chemotherapy. So as much as possible, try to give the pharmacological like prophylaxis in patients in the post-operative period. Again, when it comes to treatment, our primary goal of therapy in venous thromboembolism is to prevent the fatal outcome of pulmonary embolism, that is death. Other than that, we have to reduce the short-term morbidities associated with acute leg or lung thrombus, particularly when it comes to lung thrombus. So hypoxemia, hypotension, need of vasoactive agents, mechanical ventilation, prolonged ICU stay, all these things we have to prevent with a proper therapy. Preventing the recurrent VT is one more goal of our treatment. So preventing the long-term sequelae, again, it's if it is related to recurrent VT, recurrent hospitalization, and cost occurred because of the repeated hospitalization, that also we need to prevent with a proper therapeutic approach. When it comes to treating deep venous thrombosis, patient with suspected symptomatic acute lower extremity DVT, we have to do venous duplex scan, venous Doppler scan. In ICU, an intensivist can perform venous Doppler, lower limb venous Doppler with a 2-point compression technology, which is having a very good sensitivity near to more than 95% than continuous compression test also. If the venous Doppler comes negative, so then we have to see for clinical probability using probability risk stratification. If the probability is low, then we need to observe. If the probability is high, then we need to conduct a repeat venous Doppler or maybe venography. If it comes negative, observe them. If it comes positive, then we need to evaluate with a coagulopathy and thrombophilia workup before giving the anticoagulation. You have to remember, when you send the sample for thrombophilia workup, if they received already low molecular weight heparin or unfractionated heparin, the result may get confounded. So we have to collect the sample before giving any anticoagulation. So then we have to rule out the again hidden malignancy also. So anticoagulant therapy, if there is a contraindication, then only we have to consider IVC filter. Otherwise, if no contraindication, then if the patient is pregnant, use low molecular weight heparin. You want to treat them on OPD basis, low molecular weight heparin. Hospitalized patient, initially you can consider low unfractionated heparin. So then bridge with the warfarin or newer oral anticoagulant. So along with that, we can consider compression treatment. So, but you have to remember, first and foremost, therapy for diagnosed DVT is therapeutic anticoagulation, that is pharmacological, than the mechanical one. So again, when it comes to managing the catastrophe of venous thrombus, that is pulmonary embolism, so it is the simplest diagnostic approach. When a patient present with a suspected pulmonary embolism, means there is a new onset or worsening of the existing dyspnea, chest pain, sustained hypotension without any other obvious cause. It's very important. They should not have cause for the hypotension like hypovolemia or septic shock or hemorrhagic shock. Then we have to assess the clinical probability by using any of the probability risk assessment scoring system. So then main determining factor to go for some sort of investigation modality depends upon their hemodynamics. The patient is hemodynamically stable, then we have to see their clinical probability. If it is low or intermediate, we can use D-dimer testing. So D-dimer is having a negative predictive value, you have to remember. So D-dimer can be positive in critically ill patients. So those patients who are elderly, pregnant patient, malignancy patients. So if it comes negative, which rules out pulmonary embolism, if it comes positive, then still we need multi-detector CT, that is CT pulmonary angiography. They have a high clinical probability, so with some risk stratification, so then straight away we need to consider multi-detector CT. If it comes negative, so then we have to think other alternative diagnosis. If it comes positive, so it confirms the pulmonary embolism. If the patient is unstable hemodynamically, so then we have to assess their criticality. If the patient is not so critically ill, we have to again mobilize them for multi-detector CT. If they are like too much critically ill with a background of unstable hemodynamics, again if there is no availability of the multi-detector CT, then it is better to do transthoracic or transesophageal echocardiography. So if they have right ventricular dysfunction, so right ventricular right atrium dilatation, it confirms the pulmonary embolism diagnosis. Remember, the sensitivity of echocardiography in detecting pulmonary embolism increases with the unstable hemodynamics. If the patient becomes more and more unstable, so more and more RARV is going to be dilated. So we are able to easily pick up the pulmonary embolism as a cause for RARV dilatation. So in a background of unstable hemodynamics, sometimes we can make an attempt to visualize the thrombus in the main pulmonary trunk with the transthoracic or transesophageal echocardiography also. So when it comes to therapeutic approach, so clinically, so we have to define whether the patient is having shock or sustained hypotension. If the systolic blood pressure is less than 90, or there is a drop in pressure for more than or equal to 40 millimeters of mercury for more than 15 minutes, then we consider them as unstable hemodynamically. We go for thrombolysis. So you assess for contraindications for thrombolysis. If there is a thrombolysis contraindications are there, then we can consider surgical or catheter embolectomy. Remember, surgical embolectomy is advised when you have sufficient some sort of support with cardiopulmonary bypass. The patient is stable hemodynamically, so then you have to evaluate clinical and cardiac features. You have to do the echocardiography, multi-detector CT. So then you send some markers of the myocardial injury like troponin and N-terminal brain natriuretic peptide, that is BNP. The patient had both RARV dysfunction with the injury markers like troponin elevated. If they don't have anything, so then continue anticoagulation. We can consider them admission or early discharge on home based therapy. If they have RARV dysfunction, still we need to continue therapeutic anticoagulation, but we can consider ward admission. They have both dysfunction and injury, means RARV dilatation, dyskinesia, dysfunction, along with injury markers like elevated troponin and BNP, then it is a midway indication for proceeding with thrombolysis. So again, when it comes to overall anticoagulation plan, so if initially if you consider them for unstable hemodynamics, we'll go for thrombolysis. Hand in hand, we'll start unfractionated heparin, that is 80 units per kg stat followed by 18 units per kg per hour to maintain the EPTT around 2.5 to 3 times. You can consider low molecular weight heparin or fondaparinux in the therapeutic dosage, so it depends upon the weight of the patient. So again, if there is a contraindication for thrombolysis, we can consider percutaneous mechanical thrombectomy or surgical embolectomy. You have to consider giving vitamin K antagonists, particularly warfarin. So for like initially start in around 3 to 5 days. When you get like INR in the therapeutic range in between 2 to 3 for at least 2 readings, then we can convert them purely into vitamin K antagonist and we can stop these unfractionated heparin or low molecular weight heparin or fondaparinux. So how much duration to continue the therapeutic anticoagulation? the patient had unprovoked thromboembolism, the patient had active malignancy or recurrent thromboembolism, so then we have to continue the therapeutic anticoagulation indefinitely. Otherwise, at least more than 3 months is recommended, 3 to 6 months. So when you consider extended treatment, you can maintain the INR in between 1.5 to 1.9 also. So again, so there is a overall plan on the therapeutic anticoagulation in relation to duration of therapy. So again, there are lots of limitations of anticoagulant agents, so we need some sort of newer drugs, because so to use unfractionated heparin or low molecular weight heparin, so it is very inconvenient for the outpatient setting. Particularly we have only option is IV or subcutaneous. So again, these patients who are on heparin can have heparin induced thrombocytopenia, even though incidence is more with unfractionated heparin, which is about 2.6%. So still it can happen with low molecular weight heparin also. So even when they develop heparin induced thrombocytopenia, still they need anticoagulation. So it doesn't mean we'll stop the anticoagulation. So again, we need newer drugs, because the existing oral anticoagulant, that is warfarin, is underused in patients who need it most. Only about 47% of the patients with atrial fibrillation are taking warfarin. This is often due to some hemorrhagic contraindications. So convenience issues due to the need for frequent monitoring of INR, difficulty in maintaining the optimal anticoagulation. Even though they are taking warfarin, but many of the time, near about 25 to 30% of the time, they are not able to maintain in the therapeutic range, many drug and food interaction. So we need an ideal anticoagulant agent which should be effective, minimal complications or side effects, convenient in administration, preferably oral for outpatients, rapid absorption, fast onset and offset of action, predictable pharmacokinetics, because when it comes to unfractionated heparin, pharmacokinetics and pharmacodynamics are very unpredictable, because it is going to bound to plasma protein and endothelial layer also. It should not have any food or drug interaction, should not cause heparin-induced thrombocytopenia, no need to monitor the coagulation profile also. But it is very difficult to get an ideal anticoagulant, but we have a couple of newer oral anticoagulant agents which satisfy some of the characteristics of ideal anticoagulant. So this is the overview classification. So we have direct thrombin inhibitor, so which are classified as irreversible and reversible. If you see dabigatran, which is available, one of the reversible direct thrombin inhibitors. So factor 10A inhibitors, these again classified as direct inhibitor, rivaroxaban, apixaban, which are available in India. Indirect inhibitor, that is fondaparinux, which is available in India. So again, when to use IVC filter? If patient is having a contraindications for therapeutic anticoagulation, not able to achieve therapeutic anticoagulation, complications of anticoagulation, if they had a severe bleeding manifestation, or in patients with recurrent venous thromboembolism, we can use IVC filter, but it is invasive procedure, requires expertise. So paradoxically, risk of thrombosis is still high with the IVC filter. It prevents the embolism, particularly pulmonary embolism, but the process of thrombosis in the legs is still ongoing. So usually we have to consider as a last resort for recurrent venous thromboembolism as an option for IVC filter. We have to use retrievable IVC filter, so when required in particular group of patients. In summary, venous thromboembolism is the second most common cause of death in hospitalized malignancy patient. Malignancy patients are under prophylaxed for venous thromboembolism. Risk factors for VTE in the setting of malignancy may be related to, so characteristics of the tumor, particularly solid tumor, chemotherapeutic agent, what surgery they underwent, level of thrombocytopenia, long-term secondary prevention with low molecular weight heparin has shown to produce better outcome than warfarin. Newer oral anticoagulants have benefits over warfarin, so but we have to select an individual approach. Echo is the best modality in deciding the therapy in unstable patients. So CT pulmonary angiography is the gold standard for diagnosis. So VQ scan, even though it's been considered in pregnant patient for less radiation exposure, but there is a high chance of breast cancer on follow-up studies. Still, echocardiography, CT pulmonary angio, where to use the D dimer. So with its negative predictive value, we have to assess the clinical background to diagnose patient with pulmonary embolism. Thank you all. Please subscribe to my YouTube channel to watch more updated educational videos in critical care medicine, anesthesia, emergency medicine, pulmonology and internal medicine. Thank you all.